Welcome everyone again to another episode of the ideaXme show, that profiles the humans behind the really big ideas that are shaping our world, inspiring the future and future creators, and for all those that love great stories. I'm Ira Pastor, your life sciences ambassador along for this journey. So the term population health refers to a discipline that basically helps governments, large organizations ultimately manage the health of their populations better, primarily through infrastructure, clinical data analysis, health and disease management, and ultimately primary care. The field of virtual health, also sometimes known as telehealth in certain circles, are innovative ways ultimately to connect with patients using technologies and telecommunication systems, which can significantly expand access to care as well as increase health equity and help reduce costs. I'm honored today to be joined by Dr. Sneh Khemka, who is the president of one of the leading international health benefit services companies in the world, focused on population health. He's responsible for managing and growing this extremely important business segment in various countries around the world: India, China, South Korea, Qatar, Dubai, a variety of other locations further afield, and really implementing this concept on a global scaled basis around the world. Previously, Dr. Khemka was the Chief Operating Officer for Advanced Oncotherapy, which was involved in advanced proton therapy, and a spinoff from CERN, which was the European Organization for Nuclear Research, home of the Large Hadron Collider. Dr. Khemka was also Director of Healthcare Development and Global Medical Director for Bupa Group, which is a British international healthcare organization provisioning a multi-insurance group with origins and headquarters in the UK, serving around 32 million customers across 190 countries. Dr. Khemka originally trained as a surgeon with a specialty in ophthalmology with an interest in ocular oncology, and he continues his clinical practice as a radio doctor, where he's a popular weekly show in London, LBC 97.3 FM. He also works as an expedition medic, supporting people undertaking challenges around the world. Dr. Khemka has previously advised and acted for a number of private equity houses in the UK and Europe. He's a non-executive director of vHealth, which is the largest UK pathology company. He's an acting member of the Council on the Future of Healthcare in the World Economic Forum, and previously a non-executive director for the Joint Commission International, US-based leading hospital accreditation authority. In 2013, Dr. Khemka was awarded the honorary membership of the Faculty of Public Health in recognition of his wide contributions to the field. We have a lot to talk about. Dr. Khemka, thank you for taking the time to come on the show today.
It's a pleasure, Aaron. Thank you very much indeed for that introduction into me and my background. I appreciate it.
Definitely. We typically start off the show by giving our guests the floor for a little bit, just to really introduce themselves, talk a little about your backgrounds, or where you grew up, how you got interested in medicine, and ultimately a little bit on your path from an extremely specialized area like ocular oncology into something with a much broader purview of primary care and population health.
Well, yes, so let me take you back to the origins of becoming a doctor. I'm a second-generation Indian in the UK, and like many second-generation Indians who go into professions, it was a natural course for me to go into medicine, my father being an orthopedic surgeon. And what happens in medicine is you go through your training and you sort of choose your specialty fairly early on. And I'd chosen that I wanted to specialize in oncology. But ophthalmology was also an area of interest for me. And so I ended up specializing in ocular oncology, which is thankfully very, very rare. Rare as hen's teeth. You get melanoma, like you get on the skin, but you also get a nasty condition called retinoblastoma in young children. And what I found was in my clinical practice, I was able to affect hundreds of lives. And part of the reason to transition more into a population health and public health background was so that I could use some of the expertise that I've got to help with hundreds of thousands of lives and to make policy, business, infrastructure changes. And that's why I transitioned out of normal clinical medicine and more into the business of healthcare, if you say. And I did that with a UK-based company, the Bupa Group, and then moved on from there into my current employer. But during that whole time, I've really had an interest in public health. And I've been lucky enough to travel the world and see different healthcare systems. across the world, from developing to developed nations. And I can tell you one thing, Ira, there is so much disparity and diversity between healthcare systems. And we're recording this during times of COVID, and I think COVID is exposing what those disparities are in infrastructure. And I think as a common basic access need, people need to have access to healthcare. They need to have some quality in the healthcare that they receive. And there needs to be a minimum standard, and that does not exist. And there's definitely a polarity between the rich get very good healthcare and the poor get very poor healthcare. And so I've been on a sort of mission to try and equalize that to a certain extent. And more recently, over the last 5 years, I've spent time really looking at population health management, which is trying to harness the power of data and of digital to deliver healthcare in a completely different way. With the sea of data that we do have in healthcare that everyone talks about, it means that we can really quite quickly and efficiently analyze where issues may be and where solutions may be. And then the delivery of those solutions in a public, cost-effective manner, especially through primary care, in a digitized format, is really where I'm trying to take the next stage of my career. So it's been a wide-ranging career and wide-ranging set of things that I've done, but the mission is one thing, and that's to effect better healthcare for large populations.
Excellent, excellent. You know, you were recently quoted in an article. Actually, you wrote a piece called "How COVID-19 is Leading to a Resurgence of Primary Care," and you make the following statement. You said, "In the same way that cutting-edge drugs, surgical breakthroughs, and the latest specialized medical equipment may garner the majority of attention-grabbing media headlines when it comes to healthcare, it's really the quality of basic underlying system that makes a tangible difference to improving and maintaining long-term wellness. It may be more mundane and less discussed, but primary care really matters." And I think this is, yeah, I mean, we on this show, we obviously focus a lot on the shiny, exciting stuff that may be 10, 15 years out, and we don't think as much of primary care. But at the end of the day, as you say, if this breaks down, if we don't have this, the whole system goes in terms of not only services, but costs, safeguards, coordination across medical conditions, and so forth. Take us a little bit into this, if you would, because I think it's something that we don't talk about, or we don't think about as much when we're talking about the next generation, whether it's regenerative medicines or stem cells or gene therapies, things of this nature. But really the core of it all, the thing that sustains it all, is having a good quality primary care base to manage patients.
So the stuff that you talk about and that your normal broadcasts are concerned with are very important. You've got to keep on moving on the game. You've got to have research. You've got to reach new boundaries. And I think some of those developments are very, very exciting, but it does come at somewhat of a risk.
Sure.
And the risk is that people are diverted away from the core essence of what is important about getting healthcare to people. So the stuff that you talk about will advance science, but it'll only reach a small percentage of the population. And what I'm talking about is basic infrastructure to be able to reach large swathes of the population. And think not here just about the Central African countries with poor healthcare infrastructure. I'm talking about the US, the UK, Western Europe, Australasia, developed economies where we have quite a disparity. So what do we mean by primary care? Primary care is really the place that you go to for all of your basic healthcare needs. Now that could be one single point of contact, like a general practitioner or a primary care physician, but for a whole range of things, from if you have minor ailments to chronic diseases to mental health problems to cuts and bruises to pediatric things with kids, your first point of call in most developed economies is through your primary care practitioner or your GP, but that varies considerably around the globe, and it has various ramifications as to how well you can sustain a healthcare system. So let's take the poorest parts of society. Mm-hmm. The problem is that they don't have any access. The best that they do have is community workers, people who are very poorly trained, and only then can they get escalated up the system. And often when they're escalated up the system, they go into secondary care, they're late to present, it is at a late stage in disease, and they get treated very badly. Or let's take more developed economies, like in the United States where you are. You'll find that some people have a primary care practice that they rely on. Many other people will go straight into secondary care. And that comes with its own dangers, because then you get lack of coordination, you get duplication, and you get a lot of cost. So here in the UK, where we've got a very strong primary care system, we only spend about 8% of our GDP on healthcare, whereas in the States, as you well know, it's closer to 20%. And part of the reason for that is there is no gatekeeper, meaning that people go straight into secondary care, they get very expensive and often unnecessary care. So whether you're rich or poor, having lack of primary care is a problem. And now is the time to address that. Now is the time to put in primary care ecosystems. But the great thing here is they don't need to be delivered in the bricks and mortar facilities that we've always traditionally associated with primary care. The new physical and digital, online, offline model that is emerging post-COVID, I think is the way of the future. And I'm spending a lot of time trying to figure out how to best deliver that at the right cost for various economies.
Take us a little further into that. You've mentioned some of these new paradigms offline to me. This concept of phygital, merging the physical and the digital world. Also, what exactly is an offline hospital? We think of the bricks and mortar, but what does that really imply?
Well, let's think about primary care to begin with. So, how much of primary care do you need a doctor to physically lay hands on you for? Probably only about 25% of primary care, because 75% of primary care is done by talking, understanding, seeing, but not necessarily examining and touching. And I'm talking about mental health conditions, chronic diseases, basic primary care conditions such as strep throat or painful joints or whatever. And it's only about 25% of instances which actually require you to physically do something to someone, take some blood, measure or examine. And even in the measure category, a lot of that can now be done at home with various monitors and sent in. So why would you drag someone away from their home into a potentially infectious environment where it's expensive to deliver care when you can actually do that very effectively from home? And people are beginning to slowly wake up from this. I mean, the speed of adoption is definitely greater now. So what is an offline hospital? Well, an offline hospital can actually deliver you a lot of things. What do you need when you go to a hospital? You need to see a doctor, you need to get some tests done, or get some vitals measured, you need to come out with a diagnosis, you need to get a treatment plan, you need to get some drugs, and you may need some other adjuvant therapies. A lot of that can be done with home delivery systems or remote working. And there's this concept is really gaining a lot of credence. If you look at China, there's an outfit there called Ping An Good Doctor, which many of your listeners will have heard about. Sure. They've had massive success with their model of online, offline. And it means that people from rural communities are able to now get access to specialists that they were never able to access before. You get your things delivered in a much more convenient, cost-effective manner, and you can maintain your chronic diseases in a much more informed way because you get regular interaction, which is meaningful and helps you to modify things. So that's the direction of travel that we're going to on that.
Excellent, excellent. Something else that you've written a bit about, we've talked a small amount on this show recently, is this principle of the Internet of Things. So basically this blending of the digital and physical world where we have interconnected computing devices. Currently we can shout to our Alexas and we can have our little vacuum cleaner robot over here cleaning up our floor, but we're really moving on to sort of the next generation, what we'll call the Internet of Medical Things, the Internet of Healthcare Things. We're talking about remote monitoring, maybe monitoring in sort of the clinical setting, outside the clinical setting, sorry about that. Take us a little bit into your vision of sort of the merging of your population health concepts, virtual health, and now sort of this Internet of Medical Things. What do you see as some of the possibilities looking out, say 5 years, 10 years, in terms of this connection and sort of creating the smart home healthcare environment?
Yeah, so you can split that in so many ways. The first thing I'd say is there's a big caveat around that, both around the technology development as well as the rate of adoption. So the Internet of Medical Things, it'll take quite a long time for us to come up with technology that I as a physician or you as a consumer will find eminently reliable. So at the moment, most of those things stay within the retail environment. I trust, the big tech companies, Apple and Google, whatever, Amazon, with certain things, measuring my heart rate, maybe even a 2-lead ECG, measuring my temperature, those sorts of things. But if it comes to anything more invasive than that, then it takes quite a lot of technology advance to get to the accuracy and the specificity that's needed to get past the regulators, and that's for a very good reason. So I think the development curve on more invasive medical things outside the retail type of things, the wellness stuff, is going to take some time. But trust and human behavior is absolutely crucial here, because it is only how much you are able to trust a system will you buy from it. So I buy clothes online. That took me quite a long time to get there. I'd buy food online. Took me a bit of time to get there. I'd buy my vacuum cleaner, or I'll have a digital vacuum cleaner, as you talk about. But when it comes to medical grade stuff, people are quite naturally much more hesitant, and so the rate of adoption, I think, is going to take some time. And so when you say 5 or 10 years, I'd probably say back to you 10 or 20 years before we really get the Internet of medical things adopted. But if and when we do, here's where the vision can lay out. So talk about infrastructure for healthcare. One of the things is, how do you get really specialist care out into non-specialist units? So you may have a small district hospital which is manned by a certain level of staff, but if you've got something serious going on, you need to move out of that facility and go into a super specialized facility. How can we quickly disseminate that sort of level of care in more remote facilities? And I give you the example of ICU care, intensive therapy care. So what some new models are beginning to establish is that you can have a central control center in a big teaching hospital, and lots of peripheral hospitals that are hooked up to that. And so where patients are monitored and treated in an ICU in a smaller hospital, suddenly they can get the standards of care and standards of medical attention and advice from a specialist center using telemedicine techniques, whereby the central function can log into your remote location wherever you may be. So that's one thing on infrastructure. Two is then on sort of technology development and how we run. Let's take radiology, for example. So in the next 5 to 7 years, radiologists will become secondary check mechanisms to what automated machine learning or artificial intelligence systems are telling us about our X-rays and our CT scans and our MRIs. I would expect a machine to do at least the first or second pass read on a scan and tell me if I've got a cancer or something like that. And then I'd have that verified by a human being. At the moment, that's completely the other way around. It's human beings doing all of the readings. And that puts some pressures on the system, it decreases capacity. So beginning to turn that around for the Internet of Medical Things, I think is going to show significant change. And then third is what we adopt in our home places as well, and what we have in a more domestic environment. So if I am a diabetic, most diabetics will do a pinprick once in a while, note down a blood sugar here or there. Every 6 months, they'll have a physical face-to-face with a doctor, and they won't be able to recall what their blood sugars were doing over a period of time. That's going to change significantly with continuous monitoring, which goes into automated systems, which then issues alerts when people are going out of their blood sugar range. And that's already here to a certain extent. So as that sort of thing develops, everything from our mobility to whether we're falling over at home, to how well an Alzheimer's patient is coping, to measuring what's coming out in your pee on a daily basis, so you can modify your diet. Those are the sorts of things that are starting to creep in. And it'll be a slow pace of adoption, but I do see these things coming in.
Excellent. One more thing I just wanted to touch on the population health front. I'm by undergraduate training, I'm a pharmacist, and 30 years ago, my pharmacy was just a place where I would go in and get a prescription filled. Now the pharmacy is a much different place. A mile down the road here is a Walmart, and I can get pills, I can get vaccines, blood tests, I can see a clinician, all while I'm shopping for my groceries and other items. Are you seeing any interesting models as you travel around the world to some of these different locations that sort of are, we call it sort of melting down the old school physician office and hospital and into some interesting hybrids, such as what I see down the street here at the world's largest retailer, Walmart.
So yeah, absolutely, Ira, you're spot on, and it isn't what you say great. The fact is that it's becoming more a retail experience and something that you'll get to do when you're doing your grocery shopping. I think that's absolutely the right way for it to go, and so much more healthcare can seep into the community and into community locations. So when I talked about primary care, it's not just the primary care physician, it's all the other stuff that's based on community care, whether it's people who check your ears, check your eyes, involved in your health and well-being, your fitness, or are selling you your groceries. Because that's where people want to purchase. You know, you've always got to remember where the consumer wants to go and get things. And it's much more convenient for the average Joe to go and get their blood test done, to speak to a clinician, to get their drugs, to get their chronic disease. And the reason I concentrate so much on chronic disease is because that drives about 65 to 70% of cost and work in the healthcare sector. Yeah. And so moving into a retail environment, that's, you know, that's exactly the right thing. But let's take you to India, for example. So there's an outfit in India that's getting into the rural communities. It's a company called Vakrangi. And what they're doing is they're putting old sea containers into villages. And in those containers, they're essentially equipping them to become banks, post offices, retail outlets, places where you can deposit stuff and get packages sent to. And that's really important infrastructure for Indian villages who have no other means of communication and getting the stuff otherwise. So we put healthcare in there as well. So there's a very small station. It's just a small screen with a microphone and something to measure your blood oxygen, something to measure your blood pressure. And through that, suddenly Indian villagers who've never seen a doctor in their entire lives can get access to quite good doctors in some of the big metros who will talk them through their primary care condition, diabetes, hypertension, whatever it may be. And then you can dispense the medicines and they can get it out of these little centers that we've got. So suddenly you're moving healthcare into the community in ways that it hasn't been done before. And so I see the models like this really beginning to emerge and taking stuff out of those high towers that we built in very expensive hospital institutions and moving them to much more low cost, accessible, convenient, relevant locations. In the US, you know, there's obviously a few companies that are doing it. Walmart's done it, CVS and the Minute Clinics has been huge on this. Walgreens is going in that direction. And I think a lot more primary care will get delivered. And pharmacy is a really good place for it to be focused on.
One other item I want to touch on, we have a major demographic shift occurring. We talk about the topic of healthy longevity on this show a lot, the numbers, you know, for 2050, we're projected to have something like 2.5 billion people on this planet, age 65 or over. Population health and aging, interesting things on the horizon from your perspective, from not just from the medical side, but the insurance, the payer side. Major demographic shift, major silver tsunami, as they call it. How can these tools help with this transition that's coming fast and furious?
Well, one of the things that I haven't talked about, and just to preface my answer to your excellent question there, is data. So what's beginning to happen is we're now getting data from various sources, be that wellness devices, be that medical records, be that pharmacy, be that insurance claims, from all over the place. It tells us a lot about what's going on in society. And that then allows us to segment and understand where the drivers are of behaviors, but also of costs in society. So how does that relate to your question? What we are beginning to understand now is quite the burden that senior societies put on a healthcare system. And it's a cross that we have to bear because we are human beings and we are a society that's going to support the elderly. But there is a problem, and the problem is that it is unaffordable. It is unaffordable to continue to fund the healthcare system and to deliver healthcare in the traditional manner that we've been delivering it. So while we've got a lot of people moving to that silver generation, and if you look at costs of people, you know, from the age of 20 to about 60, if you're spending $5 a year, that goes up to about $7.50 a year from 60 to 70, goes up to about $12 a year from 70 to 80, and then rises to about $35 a year. Those are not real figures, but those are percentage comparisons over the age of 80. So suddenly, the older people going into their 70s and 80s are costing us a huge amount of money. So we as a system have got two obligations. One is the moral, which is that we need to continue to support them and allow people to live longer, healthier lives. And the second is, how do we actually do that? How do we ensure that we can do that? Part of that is the system change that I've talked about, moving healthcare into the community, not bringing people into hospital so much, being able to care for them in the community, also finding local family-based methods to care for people and to give intervention at the right points. And that's a very complicated discussion to go into, but that's part of it. Part of it is about understanding what longevity should look like, not will it look like. The aim is not just to extend our lives. The aim is to give us quality years of life. You know, that old adage, if you don't want to just add years to life, you want to add life to your years.
Right.
And so one of the things that I haven't seen come out of the longevity industry as much is, how do we ensure that people have quality and fulfilled lives, not just the sort of bioscience behind extending lives and reducing cell apoptosis and all that sort of stuff. Right. So how do we, so the two answers to your question are: one, infrastructure to allow us to support seniors as their healthcare needs rise, and two, how do we ensure that longevity progress is based around quality progress of people's lives and not just extension of years for the sake of extension of years.
Outstanding. Final question I have to ask. Obviously, we're in the middle of a rather unique time period with COVID. Number one, how are you? Because I guess I heard on a recent episode that you are a survivor of COVID. Nice to hear. But at the same time, how is everything in the UK? How is everything abroad? Seeing any interesting virtual health models that are useful in some of the other countries that are struggling more than others? Any interesting insights you might want to throw this way with regard to virtual health and COVID?
Well, of course, we have to ask about COVID, if not only just to make my background seem a bit more relevant, but yes, it's the subject of the moment. So first of all, I'm well, thank you. I had COVID about 5-6 weeks ago. I got quite a high viral load, which I think is very important in predicting how bad you're going to be. I know where I got it from. I got it from a work environment, and I knew exactly what was happening to me the moment I got it. So as soon as I started feeling a little bit unwell, it progressed very rapidly. I didn't get a test because I live in the UK. We didn't have any testing. I knew what I had immediately. So I isolated for 7 days away from the rest of my family, successfully so. And I went through various stages. I was quite unwell for a couple of days. I had a very high temperature. I had all of the symptoms. I lost my sense of smell. I had headaches. I had a sore throat. I had a cough. But physician heal thyself. I sort of understood what was going on, never panicked about it. And after about 4 or 5 days, I was getting back to normal. It took me about 3 or 4 weeks to recover in total from it. I did pass it on to my wife and children, but a very low viral load, probably left on a door handle in the house somewhere. And they were okay. They had it for a couple of days. The UK has seen a very high death rate. Part of that is because of the way we report it, but part of that is because of relative inaction from our government in early stages. And if you look at who has really worked, you know, there's a rumor going around that if your country has a female leader, you're much more likely to have had a better response to COVID. And I quote to you Taiwan, Finland, New Zealand. And what New Zealand did, I really take my hat off. They took a lot of action very early and managed to reduce the virus spread and virus deaths considerably. And I think the lessons that countries need to learn is to do what they or South Korea did, which was, you know, really to test, to track, to trace, to isolate. Because the thing that we're all going to experience are second and third waves of this. Virtual care you asked about. Well, it's been the black swan moment for virtual care. Sure. For the last 10 years, CEOs and CTOs have been trying to drag their healthcare establishments into the digital age and failing to do so. Suddenly, in 3 months, COVID has done what CTOs could not do for a decade, and moved us all into thinking about digital healthcare. And I think that this is a sustainable change. I think this is going to be a different way of working, where people will be going more into that digital environment, be much more comfortable consulting with doctors in a digital environment. And so you'll see valuations of digital healthcare companies go through the roof. You'll see lots of startups in this space. You'll see a lot of money and a lot of innovation. And I think that online, offline model, the phygital model that I talk about, I think that will suddenly gain a lot of velocity. And that's applicable to developed and developing economies. And so I'm very pleased to see that. I think it's one of the good byproducts of COVID. But my final thought on it for you, Ira, is that I think there has been a massive overreaction in some countries about how to deal with this. What I'm now worried about is what is going to be the long-term economic and therefore health, both physical and behavioral health impact on especially younger generations. Kids that are coming out of schools and colleges now, they're the ones who are going to suffer. I'm in my mid-40s and I have a relative base of stability, so I won't worry so much. But for those who are coming out into a depressed economy over the next 5 years to 10 years, I think there's going to be a lot of toll from a public health point of view as a result of the medicine that we've taken to deal with COVID rather than the original disease itself. And that requires redress and balance.
Absolutely. Absolutely. It's going to be very interesting times, extremely interesting times. Well, it's been extremely eye-opening, really, listening to your vision of what's to come. It's going to be a very interesting couple decades, and the way things are changing, the reestablishing of this primary care connection, really extremely important insights, and I really thank you for the time to share them with us. For everybody that's going to be watching on the YouTube channel or listening on the various podcast networks, you've been listening to the amazing Dr. Sneh Khemka, international thought leader in both population health and virtual health, leading international health benefits and services at one of the largest providers of health around the world. You can listen to his radio show in London, LBC 97.3. Dr. Khemka, thank you for taking the time out of your schedule to come on the show. Thank you for everything you do. And as we say on the show, thank you for moving the human story forward. And I'm glad you're feeling better and doing well. It was a really great time.
You're a gentleman to have invited me, and I hope whoever is watching or has listened to this has gained some pearls of wisdom. I look forward to speaking to you again.
Absolutely. Most definitely.